Acute coronary syndrome. Now, what is the definition of acute coronary syndrome? A constellation of symptoms related to obstruction of coronary arteries, with chest pain being the most common symptom in addition to nausea, vomiting, and diaphoresis. Chest pain concern for acute coronary syndrome is often radiating to left arm or angle of jaw. Pressure like in character and associated with nausea and sweating. Chest pain is often categorized into typical and atypical angina. Acute coronary syndrome. Based on ECG and cardiac enzymes, acute coronary syndrome is classified into STEMI and non-STEMI and unstable angina. So STEMI means what? ST elevation is there, elevated cardiac enzymes are there. So that is ST STEMI. And what is NS STEMI? ST depression, that is non-ST elevation MI. STEMI means what? ST elevation MI. In NS STEMI, you will see the ST depression, T wave inversion, and elevated cardiac enzymes. And the third entity, which is called as unstable angina. So, in unstable angina, the cardiac enzymes are normal and ECG changes are very non-specific. So that is called as unstable angina. Now again the J point. So what is J point? We have already uh, discussed. J point is seen where the QRS complex and ST segment meet. So ST segment elevation evaluated zero point zero 0.04 seconds. So 0.04 seconds means what? One small box after the J point. So you can see this is a J point. So ST segment elevation. So after this J point, the ST segment is elevated. After this J point, the ST segment is elevated. Now there is a anatomical group. So these are the leads one AVL and V5 V6. They indicate the lateral. First, we will see as per the highlighted part V1, V2 septal. Then 1 AVL, V5, V6 lateral. 2, 3 AVF inferior. So, if you see the changes in 2, 3 AVF of the ECG, then inferior wall of heart is likely to be involved, or it is involved actually. So here the complete picture 2 3 AVF inferior, 1 AVL V5 V6 lateral, V1 V2 septal, V3 V4 anterior. This is very important. Non ST elevation MI. So here ST depression or T wave inversion without Q wave in two contiguous leads with prominent R wave or RS ratio more than 1. Isolated T wave inversion. So, isolated T wave inversion means it can correlate with the increased risk of MI, and it may represent the Whelan syndrome, that is critical left arterial dilatation, that is LAD stenosis, and more than 2 millimeter of inversion in anterior precordial leads. Unstable angina. It may present with non-specific or transient ST segment depression or elevation. So evolution of acute anterior MI at 3 hours. So you can see after the J point, the ST segment is elevated. So this is ST elevation in V5, V6, or V2, in V2, in V3 you can see. So this is the acute anterior wall MI. Lateral MI in AVL, you can see the ST elevation. You can see in first lead, AVL lead, V5, V6, the ST segment is elevated. So it is lateral. Inferior wall MI. So you have 2, 3 and AV, 2, 3 AVF. So you can see here also the ST segment is elevated after the J point. So inferior wall MI. Metabolic factors and drug effect. So, hyperkalemia produces a sequence of changes, usually beginning with. So, narrowing and picking, narrowing and picking of T wave. So, metabolic factors and drug effects, they are always be seen by ECG. So first is the hyperkalemia. It produces a sequence of changes, usually beginning with. So narrowing and peaking, that is tenting of the T wave, AV conduction disturbances, diminution in P wave amplitude, widening of QRS interval, cardiac arrest with a slow sinusoidal type of mechanism. So it is a sine wave pattern and there is a asystole. So you can see the severe hyperkalemia here. So hypokalemia prolongs the ventricular repolarization, often with prominent U wave. Hypocalcemia typically prolongs the QT interval. Hypercalcemia shorten the QT interval. Digitalis effect, we have seen short QT interval, often with a characteristic scooping of ST-T wave complex, which is called as digitalis effect. Now the classification. So the classification mainly includes the sinus bradycardia, junctional rhythm, SA block, AV block. SA, that is sinoatrial block, and atrioventricular block. Sinus bradycardia. Sinus bradycardia, so the heart rate is less than 60 beats per minute. Rhythm, if you see this ECG, heart rate is, you have to calculate the small the large square between QRS 1, 2, 3, 4, 5, 6. 6, or you can, yeah, so 300 divided by 6, so it is around 50 to 60. So this is less than 60 beats. Rhythm is regular. You can see each P wave is followed by QRS complex. Each P wave is followed by QRS complex. So rhythm is regular. P wave before each QRS complex is seen. PR interval you have to calculate. QRS interval you have to calculate. Junctional rhythm. So junctional rhythm, here you can see the heart rate 40 to 61, 2, 3, 4, 5, 6. So 300 divided by 6, again it is between 50 to 60. Rhythm is regular. Can you see P waves here? No. So inverted, and P waves are inverted and absent, or they are after the QRS complex. So I think the P wave is absent here. P wave is absent here. So this is called as junctional rhythm. Then SA block. Sinus impulses in blocked is blocked within the SA junction between SA node and surrounding myocardium. Occurs irregularly and unpredictably, present in young athletes, digitalis, hypokalemia, sick sinus syndrome. So this is the sinus arrest. Sinus arrest. Now AV block. So there are three types of AV block: first degree AV block, second degree AV block, and third degree AV block. First degree AV block, there is a delay in conduction through the conducting system. Prolonged PR interval. All P waves are followed by QRS, and it is associated with acute rheumatic carditis, digitalis, beta blocker, excessive vagal tone, ischemia, intrinsic disease in the AV junction or bundle branch system. So this is first degree AV block. So PR interval is prolonged. Second degree AV block, intermittent failure of AV conduction, impulse blocked by AV node, Mobitz type 1 and Mobitz type 2. Further, it is classified. Mobitz type 1 is again called as Wenkenbach phenomenon. So you can see this is Wenkenbach phenomenon and this is Mobitz type 2. Third degree heart block, the complete heart block evidenced by the AV dissociation. A junctional escape rhythm at 45 beats per minute. PP interval vary because of ventriculophasic sinus arrhythmia. So PP interval is different here. You can see. So this is complete heart block. So in this, what is the rate? 1, 2, 3, 4, 5, 6, 7, 8. 9. So 300 divided by 9 or 10. So it is 30. Regular, each P wave followed by QRS, each P wave by followed by regular. P waves are normal. PR interval 0.12. QRS duration is also normal. So it is a sinus bradycardia. Again, you can check this. Rate is normal, rhythm is normal. Rate is high, is more than 100. So it is 130 approximately. Regular rhythm. P waves are normal, you can say. PR interval is also normal. So it is sinus tachycardia. Atrial flutter. So you can see the sawtooth like appearance of P wave. So it is flutter wave. So it is the atrial flutter. Atrial fibrillation. So no P waves here. So no P waves here, you can see here. No P waves are here. So this is atrial fibrillation. So deviation from normal sinus rhythm, the heart rate suddenly speeds up. So there is, see here, the initial the rate is slow and suddenly it speeds up, and often triggered by a PAC which is not seen here, and the P wave are lost. So suddenly the activity of heart is speeded here. Ventricular tachycardia, impulse is originating in the ventricle, so no P wave. So here the ventricular tachycardia, wide QRS complex you can see here. So VTAC, that is ventricular tachycardia. Ventricular fibrillation, completely abnormal. In VTAC, wide QRS. So this is a valvular heart disease, aortic stenosis. So left ventricular hypertrophy, which is found in approximately, this is all theoretical. Mitral stenosis, AF. In MS, the mitral stenosis, AF is very common. And in AF, you have seen the P waves are absent. And in atrial flutter, sawtooth appearance of P wave. MR, left atrial enlargement, all the features of LAE will be present here. We have already seen this LAE. ECG, signs of acute pulmonary embolism. So sinus tachycardia is there in 8 to 73%. P pulmonale, rightward axis shift, inverted T wave, S1Q3 T3 pattern, clockwise rotation, RBBB, A for atrial flutter, and no ECG changes. So these are the signs of pulmonary embolism. Pericarditis. The ECG is the most important laboratory test for diagnosis of acute pericarditis. The classic finding is the diffuse ST segment elevation in all leads except V1 and AVR. So all leads there is a ST elevation except V1 and AVR. ST segment is usually curved upward. PR segment depression is also common. PR depression can occur without ST elevation and be the initial or sole ECG manifestation of pericarditis. ECG reverts to normal during days or weeks. So, what we have seen, ST segment elevation in all leads except, so you can see the ST elevation in all except in V1. Here is not this, and here is also no elevation. So except V1 and AVR, in all leads you can see the ST elevation is present. So this was all about ECG. So this is very important topic. You just go through all the important notes and ECG shown in this chapter and start practicing with your patients. Thank you. Thank you so much.